So I'm with Amir Kaki, Director of the Cath Lab at the Detroit Medical Center and the highest enroller in the National Cardiogenic Shock Initiative. So Amir, I wanted to ask you, you guys have a well-developed weaning protocol that you use that's highly successful and something that you're about to publish. Would you be able to share with the other investigators in the National Cardiogenic Shock Initiative how you're weaning patients and what they can do to get the outcomes that you've gotten?
Yeah, I think weaning is probably one of the most important things about the initiative, and I think the key to weaning is it's guided all by the right heart catheterization. The other keys to weaning are hemodynamics and biomarkers. Obviously, this is a shock cohort of patients, so ideally we unload the ventricle for at least 24 hours before we assess weanability. The weanability of the patients is really guided by hemodynamics, the right heart catheterization, and biomarkers. The first thing we do when we're trying to wean a patient, it's important to try to get the patients off pressors and inotropes. Once that's accomplished, we slowly wean the device from levels of support, usually one level every 1 to 2 hours, depending on your protocols. Beyond that, once the patient is on low level support, what we consider low level of support being P3, we like to have a cardiac power output above 0.8 and a mixed venous O2 above 55. We find that those are very good predictors of successful wean. Other biomarkers that can predict successful wean include the lactate, and the closer the lactate is to 1, the higher likelihood of a successful wean. We also, within our institution, like to look at PA diastolic pressure, and arbitrarily we find that a PA diastolic pressure below 20 portends an optimal weaning condition as well.
Amir, I think that's fantastic. I think that's going to really help a lot of the sites be able to have a predictable pattern of how to wean patients in these scenarios. Yeah. In fact, we looked at this in the national initiative as well, and when we had lactate levels less than 3, with power outputs greater than 0.8 watts, we had fantastic outcomes with overall survival rates very high, and in our cohort they were 95%. However, when the lactate levels grew above to 3 and the cardiac power output was less than 0.8 watts, then the survival was much lower, and in our cohort was 36%. So in this group, you're thinking about escalation of therapy, and when lactates are less than 3 and your cardiac power output is greater than 0.8, I think you can start thinking about weaning those patients.
Yeah, I agree with you. I think it's very reassuring, the data that you just talked about, and our experience that now we have very good parameters that predict a successful wean and giving our patients the best chance at native heart recovery.